Hello? Okay, perfect. Hello, welcome to our talk. Welcome to the last day at the Medica. We'll be talking about insurance systems today and insurance models, how you can disrupt them, why they're so difficult to disrupt. And we've got an excellent panel here who will give you lots of different insights from very different players. So let me introduce them quickly so you know who you'll be hearing today. So in the middle, we have Marina Schmidt. She's a representative of statutory health insurance at the German Social Insurance European Representation, where she represents the interests of the German statutory health insurance, gives advice to EU institutions on issues relating to German social insurance and German social law. Previously, she studied health economics and health management and general management, and before starting her work in Brussels, she worked in the policy unit of the DRK Gesundheit. Hello, Marina. Then we have Benjamin Westerhoff. He's the BARMER Head of Health Management. He assesses and coordinates all digital health products and activities out of a healthcare perspective. He started out in healthcare by training as a social insurance clerk and then studied economics with a focus in international business relations. And right now he's actually working on his PhD in public health, so an interesting public health perspective as well. So welcome, Benjamin. Then, on the far end, we have Dr. Kai Orner. He's Senior Consultant Public Sector and Health Insurance Funds at PwC. He and his team held statutory and private health insurances with process optimization, digitalization, as well as change management. He has a background as a social insurance trainee and economist, and is specialized in social innovations in a German health system that cross sectoral boundaries. So he'll be able to give us some insights on that as well. Welcome. And last but of course not least, Glenn Bilby, the CEO of Kinematic, a Swedish software development company specializing in digital human movement analysis, applied science, and service design. Glenn has worked internationally with sports performance testing, private and public healthcare, insurance medicine, and health technologies for over 30 years. So a very, very large chest of knowledge that you bring with you. Thank you very much for joining. So as you can see, a wonderfully diverse group of panelists today who will give a wide range of insights into this topic. So let's get started. Let's start with the person who's actually at the center of it all, the patient or the user. So let's kick off the discussion there. So maybe we start with you, Marina, because you will have a very broad view on that. What are the needs of the European customer, or should I maybe say customers? What are their needs? How has it changed?
You hear me? Yeah. So thank you very much for having me here. Yeah, talking today in Düsseldorf at the Medica, I would then, talking about the patient needs, the insured needs, or the customer needs, I would like to broaden the view to the European perspective, as I have been working in Brussels now for the statutory health insurance funds for several years. Well, the German patients are part of 500 million citizens in Europe, spread to 28 member states. And these member states have very different economic strengths, have different cultures, different histories, and very diverse societies at the end. We have 24 EU official languages, and we have daily ups and downs of the national policies. So this leads also to the fact that we have 28 completely different health and social care systems, with systems of kind of Bismarck and Beveridge and all kinds of mixtures at the end. Well, and then if we're talking about the German patients, do we have gaps in the German healthcare systems or any grievances? Well, and I'm always saying, well, let's have a look at our neighbors and what are the other member states doing. And what are the patient needs of the other member states, and what actually characterizes the German system. So let me give you a few examples. So the German system is not financed by taxes, as we have in the UK, where you have annually debates about the budget, and the budget for health competes with the budget of other policy areas. Or like in Greece, as all of you know, the economic crisis had a direct impact on the healthcare system, and where seriously basic healthcare access to basic medical health care is not possible anymore, where you need to bring your own equipment to the hospitals. So these are not stories, but this is real. So we have in Germany a free choice of doctors. We don't have this in Scandinavia, where doctors, general practitioners or specialists are determined. And in Germany, we have a quick access to innovative medicines because we don't have the vierte Hürde. And other member states, like in Eastern Europe, especially in Estonia and Lithuania, you are waiting for new and innovative medicines for years. So Estonia is saying innovative medicines are coming 2 years later to their market. And it's especially important regarding hepatitis C, cancer, or orphan drugs. The patients suffer, or if the products are coming, the healthcare system cannot afford this because we are talking about high price medicines. It's not affordable for them. And finally, Germany has a high quality system, and we observe this when we have a look to the patient mobility statistics. So patients are coming to Germany to have health care. The German patients actually do not have a real reason to go abroad, maybe for medical spa and so on, what we register. So to sum it up, the German quality and the sustainability of the German healthcare system is doing fine compared to the European standards. The only thing I think where we really need to do something, one of the things is the integrated care, what I can mention for now, where we should improve, so between ambulatory and hospital care, and especially between specialized and general practitioners, especially for chronic diseases that could become a nightmare.
Maybe I can pass it on to Kai at this point, who can tell us something about what you have seen in terms of the changing needs going across these different sectors.
Yeah, in my opinion, we need a platform to communicate with the doctors, the hospitals, with the care facilities, with digitalized processes that they have, that you have. Yeah, even my blood type isn't on my card, or if I have allergies, and if I'm in a car accident and I'm not able to speak, no one doctor knows what I have for diseases or something else, and this is a shame. I have a twin brother. My twin brother is not able to use penicillin, and if he's in a car accident, he won't die, but he have a lot of pain. And it's totally easy to have an app or something like this, and you can put it on and say, hey, here's my health data, and I'm not able to use this, or I have an allergy against aspirin or something like this. So
maybe we can also hear what Debama is doing in terms of that, and what you see also in terms of changing customer needs, as you've got such a big group of patients to take care of.
Yeah, it's 9.2 million, a little more than 9.2 million right now. So we have kind of responsibility right there, and we're working on it. I think from the insurer perspective, it's mostly about not paying the healthcare at this point in time. It's about navigating the patient through the system and telling him what kind of services he's able to take for in a certain situation when he needs it, and not have him browse through all the possibilities there are and find what he needs. So it's got to be more like more of a service and less of a demand, which is taking place right now. And in terms of the EHRs, the electronic health records, as some of you may know, this is taking place in Germany now. So politics want to see it in 2021, which is quite some time down the line, but still. As soon as we achieve this very, very important thing, it's going to improve a lot. Because all of the things that Kai just mentioned, and also secondary anamnesis and all of that can be prevented by only seeing what the patient has already got, will be a large step forward and a real progress in the healthcare space here in Germany.
In terms of, you guys talked a lot about digitization. It'd be interesting to hear from you as well, Benjamin. Like, is that really suitable for all of your customers, for all of your patients? Like if I think of my mother, for example, she's over 70. I'm just training her on the Amazon Fire right now, and Skype, it's a bit tricky. So how do you deal with that as insurance as well?
Yeah, that's a pretty common point. So of course, digital solutions are made more for younger people. And that's also something that we have to deal with when people tell us that we are only caring about them, about the younger people, because they're more attractive for an insurer, of course. But that's not the point. So if you want to switch from a more curative to a more preventative system, then you have to start at one point in time. And you have to start with the younger ones that are still healthy. And so I don't see a problem between those two lines. So you can align this, and also I want to mention that digital solutions are not only made for younger people. So for instance, we have a project which is taking place in care homes, and it's called, RetroBrain is providing it, it's called the Memora Box, and so the inhabitants of the care homes get some kind of Wii, so they play a game, actually, so something like motorcycling or bowling. And yeah, this might sound ridiculous, but it's training their mobility. It's a social thing, so they're coming together, talking to each other. That has a huge impact. And it's also about cognitive processes in the head, which are improved. And we are evaluating this right now. But this is a big counter-argument, I think, for that it's only made for younger people, because this is not the case. And also, the people who are in between not being able to deal with digital solutions or with a smartphone is decreasing very, very fast. So at some point in time, maybe 10, 20 years down the line, it's not going to be a problem anymore because everybody's used to the smartphone and what it enables you to do.
So you're telling me there's still hope for me training my mom and getting her on board. That's great to hear.
Yeah, just keep trying, I guess.
Perfect. Maybe we move on to you then, Glenn. Having worked in the industry for so long, and also now with your current product, I understand that it looks at posture, both prevention and rehab. So how do you see, what have been the changing customer needs there, and what's your take on that?
Sure. So we look at movement patterns, the way people move, and analyze it digitally. Most of you look at each other when you walk and when you sit, and you get body language from the way people perform, if you like. You can tell what their mood is. You can tell if they've got some sort of physical problem. You can get impressions about who they are as a person. These are all very real phenomena. In sports medicine, we've been measuring people in 3D since the 1980s, you could say. But it's been so expensive that it's only Premier League footballers and gold medal athletes that have had access to it. It's a big laboratory. You'll see some of these people, suppliers in the other hall. We've created something where you can scan everybody. It's off-the-shelf equipment. The software uses different algorithms to analyze things in a way that humans can't. So the end result of this is that we can get objective information about the way people move, their balance profiles, and what their posture is, and identify if they have existing problems, and in the future predict if they're going to get future problems. So it becomes a crystal ball, basically, of how are you going to look in the near future and the far future. So musculoskeletal problems, arthritic conditions, fall detection, you name it, there's a bunch of things. Neurological disorders, MS, Parkinson's. We think we can pick up early signs of MS in young ladies, for example, based on their movement patterns, as opposed to taking some cerebrospinal fluid and doing an analysis of it and MRIing their neck. If you could pick up a 25-year-old with early stage MS and give them medication at 25 instead of at 45, the consequences of her ability to live independently and have a good quality of life are hugely different. If you take elderly people and you pick up early signs of movement disorders in the way that they go up and down stairs or take a step, and you can see that their body weight is not managed very well. Take a middle-aged man with a little bit of belly because he eats too much food and drinks a little bit too much beer, starts to get small. changes in the way he moves, which 5 to 10 years later manifests in severe osteoarthritis in his knee. If you could pick those things up, you would avoid huge amounts of costs. So the private insurance sector is quite interested in this because they're thinking more long-term about their long-term business, particularly the reinsurers, because they're responsible more or less for the entire health insurance industry. But we don't see the same sort of engagement from the public health. The political cycles are short, and therefore they're sort of thinking about how do we play catch-up here, and how do we take care of our budget this year and next year, whereas the private actors, from our impression, they're much more invested in what's going to happen in 20 years' time. If you take the musculoskeletal statistics from private insurers, it's around about 25% of all their costs. Now, these are companies that manage billions of euros, and globally, they're all experiencing the same thing. If you look at fall risk, you're looking at around about 30% of the population above the age of 50 that fall, and the burden of care costs and the orthopedic costs of a fractured hip completely avoidable if you stop someone from falling in the first place. But right now, the public health definition of fall detection is to give you a watch with a sensor that sends an alarm if you've already fallen. I mean, that's like giving somebody a sensor in a car which says, after you've had an accident, we'll send someone to help you. These days, there are sensors in cars that detect the movement of the car and can predict your driving behavior, which then affects how much you pay in your insurance policy. We could do the same thing with humans. The technology's there, we just haven't caught up with it at this stage. One more thing, when it comes to elderly people, I totally agree with you. In Sweden, we do a lot of statistics on basically everything. And when it comes to the elderly populations in the pensioned group, they're actually very, very good at technology adoption. They have no barriers whatsoever to using digital health. If you look at the lifestyle disorders and the majority of costs for healthcare in Sweden, around about 75 to 80% is lifestyle disorders. Diabetes, cardiac disease, you know, all the big ones. Most of these things are prevented if you address very weak signals of lifestyle problems. So, I hurt my knee, I get pain in my knee. So I stop walking. So I sit on the sofa and watch Netflix and eat Pringles. Then I get overweight. When I get overweight and don't exercise, I get type 2 diabetes. We need to stop addressing things when people are broken and start addressing things using computer-assisted decision support when we pick up weak signals of somebody having a causative factor, not the symptom of the causes. The other thing we can address is secondary problems. Lots of people get one injury, which leads to another, which leads to another. So right now in insurance, if you look at the biggest issue, it's mental health. Mental health issues are often secondary to musculoskeletal problems. You take a generally healthy person like myself that runs a marathon once a year, and then I get arthritis in my knee and I can't run and I get depressed and I suddenly have a mental health issue which is secondary to a musculoskeletal condition. And we've got all these very clever medical people, but they don't seem to be able to work that out. It's quite common sense. Digital health could really help us track those sorts of factors.
Yeah, Glenn, so let me reply to that. A few very good points, or a lot of very good points. I think from a healthcare payer perspective, the problem here is, so you have quite a big difference between, at least in Germany, between the privately insured population and the statutory insured population. So we are walking a thin red line, which is paying for prevention, to do that in 20, 30 years to come. And also we have this large burden of paying for all the diseases that have already taken place and that need to be taken care of, and this is quite expensive. So to allocate between those two lines is not that easy, and it's probably not enough money on the prevention side right now, but I think the private sector, at least in Germany, has a comfort in paying more for prevention, first of all, because it affects them more in the cost that the specific patient causes right after that. So we're paying it collectively as well. So we pay the doctors a huge amount of money and say, now it's your problem, deal with it. So if you speaking out of pocket, so. And this is quite interesting about it. And also it's about how to make a very pointy target group. You can equip all the people there are with all the sensors there are, but you would have to pay for that. And our problem is to find out which people can, which people can really benefit the most out of it. So, and if we're talking about people falling, and having predicted the first fall, that's all. That's not predicted. Having seen the first fall, that's the best predictor for the second fall. So hopefully, no bone has gotten broken during the first one, and then you can intervene and try to equip prevention programs to make it better in the future. But you can't pay it for each and every one, and that's the problem we're facing and that we're in. So I think that's all good and fair, but we need to have the target group narrower than just equipping each and every one.
Yes, I think one of the biggest problems is that the statutory health insurance companies have to think in 1 year, in one budget year. And with prevention is for 20 or 30 years, and then you have the effects. And then we have to change it there. Yeah, you need money for 5 years or for 7 years to have projects for this kind of time that you can show that there's a effect on the people. Yeah, and after 1 year you have no effect with prevention. Yeah? And so I think we have to change this.
So we do some work in Asia, particularly in Malaysia right now. And it's normal for people to do an annual health check as an employee of a company. And the reasons are quite obvious. Take European statistics. If you're away from work for 1 day, the cost to the employer is 8 times that day's salary. This is a typical direct and indirect cost calculation. So the argument for an employer to do preventative strategies is very obvious. If you go to Sweden, you need to get your car checked every year. They're looking for problems with your car. Sweden has the best road accident statistics in the world. They design, Germans might disagree with this, some of the best cars in the world. They know fantastic information about traffic and how it behaves, and therefore they can manage the traffic quite well because they look for problems every single year. And if your car has the tiniest little problem, you have to fix it, otherwise you can't drive your car. Now, if we can do it with vehicles, why can't we do it with people?
Yeah, it's a fair question. So I think here in Germany it's quite difficult when it comes to data protection. So people are very, very aware of this. And let me give you an example where this is even more obvious, but quite hard to do. So we have a big project called ADAM, and it's about pharmaceuticals and safety of pharmaceuticals, not the process behind it, so not the pharmaceutical itself. So telling the doctor at the point of care, at the right time, this patient has 3, 4, 5 other drugs already given by another doctor, so you are not able to know about them. And also, you're not able to know all of the adverse events that might occur when you combine the two of them, because there's just too many. So every doctor that would tell you he's capable of doing that is lying, because it's impossible. It's like knowing a whole telephone book, speaking in parsed terms here. So, but even there, we have a very large discussion about if it's okay to take the data that we have, so the insurance company gets all of it from every doctor, obviously, as well as we get the diagnoses that are there, and then we give it in a bundle to the doctor who's seeing the patient right now. And we have a lot of discussion about this, if this is right and doable under the data protection laws. And at one point in time, we have to ask ourselves the question, what is the bigger value here? Like saving the life or having the data protected a little more in every single patient? So that's not so easy to overcome.
Yes, and I think data protection is just for the healthy ones. Yeah, my father has cancer, and he talks about it. Yeah, he wants to have good data to have new drugs. Yeah, now he has a cure. He's just fine. But for him, data protection, he say, I don't like data protection. I want to be healthy again. And so I think in Germany we have so much data protection, it's not good for the health for the people.
Yeah, speaking on data protection, so we negotiated in Brussels the EU data protection regulation for about 5 years, and I can say you this was one of the hardest work we've been done in the recent years, and of course the data protection discussions are going on in a completely other way in Germany than, for example, in Eastern Europe. So, and that's why it's always the question asked, okay, are the other member states more progressed with regard to digital health or e-government and all this stuff as Germany because of the data protection issue? Well, the Commission is forcing a lot e-prescriptions and the electronic health record. These are the both two digital areas where the Commission sees a clear added value at European level in order for the cross-border exchange of e-prescription and the cross-border exchange of European electronic health records. So, and of course, you can't only start with a cross-border exchange as soon as you have a national system. So this is always the question of where it should start and where it should end. From European perspective, I can say that they're very glad to hear that Germany is now doing progress also in the e-prescription, because this was for a very long time a completely dead aspect. And regarding the electronic health records, so we are standing in front of Commission recommendation, which will be published in January 2019, where explicitly Germany should have a look on this. So it's about the technical specificities a national electronic health record should contain in order to be able to speak with the other electronic health records, so regarding the interoperability. This is what's staying in front of us, and it's a very interesting matter.
Do you find that there are any insurance systems and health systems that actually promote innovation and actually make it easier to bring things into it? You have an overview of 28 different systems. Do you find that there are specific ones that block it? And maybe after you answer, I'd also like to pass the question to Kai, especially when it comes to cross-sectoral initiatives. Are there any systems and models that really help promote that and make it easier?
Well, talking about innovations, my impression is that Germany is in the lead because innovations are coming directly to the markets, innovative medicines, and also in the hospitals. So we have now the regulation on health technology assessment. This is after the market access of pharmaceuticals and medical devices was regulated at European level, so pricing and reimbursement is still member state competence, and there will be no changes. But in between, we have the assessment. And this is now the hot burning topic in Brussels, how we are going to regulate the health technology assessment. So in the scope are medical devices as well. This is also a political issue. Should it be inside or out of the scope or in the scope? But here we have the question also with regard to innovation. Do we have a common assessment at European level with all HTA bodies, who has far, so Germany with IQWiC and GBA. In France we have HAS or NICE in UK. But several member states do have nothing regarding HTA. For example, Croatia, so there's the ministry with maybe 1 or 2 persons who are taking care of HTA. So this is a discussion now between bigger and smaller member states. Bigger member states are like more carefully. They say, okay, we have very well established systems, so what will happen now if we have joint assessments at European level? And smaller member states, well, they see a clear advantage, and there is maybe being a paying system at European level, and they can provide the results in the member states. So I think the discussions will still go several times. The medical device regulation was also discussed about 5 years before EU law got adopted. So there is another time period, as we know from national. But this will answer also the question how we're going on with innovation and how quick innovations got to the reimbursement systems of member states.
Yeah, tough question. I like the thinking about pay for performance, but I haven't seen a model where you can see where you can use it for in the real world. So yeah, I like in Baden-Württemberg the Gesundes Kindsigtal, the project where you have one service management provider, and he has the data. He have every 2 years you have to go to the doctors for a big checkup. I like this, yeah, to not to go with 40 or 50 to the prevention doctors as well in my age, yes, and then you can see maybe in 10 years I will have diabetes and now I can do something, or if my back is hurting and in 20 years it's gone totally bad. So I don't know a good model to switch our actually health model. I think we don't need a revolution, a total revolution. We need evolution, and we have the digitalized processes in a lot of other business sectors. And in the health sector, if you go to a German doctor, you think they're stuck in the 80s. Yeah, there are a lot of papers. There are maps and something like this, and you say, where are the computers? Yeah, or where is the data? And you have to fill with a pen everything, and if you go to another doctor, you have it again and again and again. And if you have a chronic diseases, you have to go to a lot of doctors, and no one knows the data of the others. And it's for me, it's a shame.
But if you say that, if you go to a doctor in Germany, we're kind of stuck in the 80s, everything's still on paper, then why should we have evolution? Why do we not need something that's quicker, that will benefit the patients more quickly?
I think that German persons are not so good with revolutions. We like our data protection. We like that we are not so like the Americans to say yes you can. Yeah, Germans often think in problems. Yeah, it's sometimes it's a shame that we are so problems orientated. But in a way, I like it more because I think that some of the Americans they talk about a lot, and the doing after it, it's not like that what they say. So
maybe I can also pass to. So you have supporters in the crowd.
Thank you.
Maybe I can also pass the question to Glenn. In terms of your experience working two different models, have you seen that there are specific models, be it a one-payer system or like German, this kind of dual system, or even a more consumer health-oriented market that actually allow you to enter and deliver benefit to the patient more quickly?
Okay, so just so you know, I'm a little bit socialist as a person because I believe in humanity and giving service to each other, and that's kind of the meaning of life. So that's where this is coming from. There needs to be a safety net for people who don't have enough to provide for themselves. This is good for the economy and it's good for the individual. But if you have the money and you want the top surgeon or the top personal trainer, you should absolutely be able to pay for it. If you can afford to pay an insurance company that would pay for it, and you're clever enough to do that, to invest in your future health, then you should be able to do that as well. Sweden's an interesting phenomenon. Doctors don't get paid so much. Everybody seems to get squeezed into a middle bracket. So if you're an excellent clinician, you don't necessarily get paid more. So what happens is they go across the border to Norway, where they earn quite a lot more. Even a good nurse gets paid 30% more just as a basic qualified nurse. We have to remember that healthcare is also a market. And unless we live in a communist regime where somebody decides over everybody, we're not going to design the perfect healthcare system because there's lots of factors. As an enabler of healthcare practitioners, providing them with tools enables them to do their job better, I much prefer private. Private people, private payers, sit back and do the mathematics without any political pressure. The only political pressure they have on them, I'm oversimplifying this, is it legal or not legal? And they're paranoid about not doing the right thing. Their brand is at stake and they care about that. Generally speaking, a little bit reflecting on this discussion we just had now, We need a complete paradigm shift about health. We need to stop providing sick care and start thinking health care. Now, when I'm in Asia, they have a tradition of wellness. They have a tradition of balance. They have a yin-yang philosophy that goes through their entire life. When I'm in the West, I feel like I'm in a mechanic shop and you drive your car in if you're broken and you get it fixed. And if it still moves, fine, keep driving it until it crashes, which I think is absurd. Now, I come from sports medicine, so I have the luxury of keeping people on the field. That is my job. My job is not to fix people when they're broken. It is to make them perform optimal and keep them kicking goals. That's my job. So I have equipment that I need to monitor their performance. I get longitudinal data on all my athletes. I know when their heart rate variability changes, they're about to catch a cold. So I tell them to rest and they play the next game instead of being off sick for 2 weeks. This would be an optimal social healthcare system. But implementing it, that's a complete nightmare. I'm not sure how that's going to happen.
And let me jump into that. And I love the point you're making, and I love how you're making it. I think the lever, how to make the evolution at least close to a revolution, is if you tie the payment for the healthcare professionals to the quality they are delivering. And this is not taking place right now. So you can completely F up what you're doing and getting the same amount of pay that you would get if you do it very, very good. And the EHR system, so the electronic health records, might be a very big enabler to turn that around. So all of a sudden you have data, you can enrich in it by patient-reported outcomes as well, and tie the payment to it afterwards. And then you have bonuses, and you also have malices, and it's getting more or less. And that might be a big lever to even get the last physician out of its corner who loves his fax machine and all of that, and is trying to do only the things he really, really has to do to keep his business going. And yeah, I think that's a level we should talk more about. And I think the discussion in Germany is going towards that. And it's also something to cut down on costs, which is needed as well.
Okay, so you asked about innovation, and I work a lot with innovation in Sweden on sort of national level and then university level and then in our own little garage building stuff in our lab. There is clinical innovation, which is about new services, novel services, or combining things to make a new service. And then there's process innovation. To me, the medical journal is process innovation. It's optimizing administration of healthcare. What's missing is getting value out of the data that's inside the medical journal and turning it into novelty. We're so focused on investing in process innovation that the clinicians, they don't even understand digital health because they're not involved in it. It's all techies coming in, putting wires and bits and bytes together to make things go faster, more fluid, and replace the fax machine. In Sweden last year, nurses who go out to the islands of Stockholm on a boat now go with a tablet PC. Last year, 2017, was the first time anybody in Sweden had a tablet on a home visit with a nurse. Now, if you said that to somebody who works in engineering in a car manufacturing, they'd say, "Are you kidding? We were doing that 10 years ago." Now everybody's talking about AR and VR and mixed reality. It's been around for ages, but medicine still hasn't adopted it. And it's because we're not involving and co-creating things with clinical people. The clinical people should be driving this, not the techies, and definitely not the people in grey suits managing the budgets. It should be the clinical people. They're the experts. So if we can manage to get them involved at grassroots, incentivize them by giving them resource slack, because quite frankly, they have too many patients, too little time. That's why they use pen and paper instead of using technology. We educate them about technology at university instead of getting them to catch up with it when they're a 50-year-old GP, because they're not going to do it. Then I think we're going to see a lot more adoption of existing technology and a lot more clinical innovation. If we could collect data on a national level and see it as a knowledge base and then exploit that knowledge base across healthy populations, which are baseline data, moderately healthy populations which are on the way to getting diabetes and arthritis, and then the sick patients as the last priority, we would suddenly have a university of healthcare across the entire country instead of fragmented in different parts of Europe. This, to me, would be the next step to a very nice healthcare system.
So you mentioned a lot that we should try and help educate the clinicians so that you can drive clinical-based innovation, etc. Both of you talked about the doctor and what the doctor is doing. What about the patient themselves? Have we trained the consumer, the patient, to basically just go to the doctor and then not take care of themselves, not bring the car, which is the body,
Right.
into the workshop to get it checked out?
Right, and that's a very good question. Okay. I'm Australian and I say things quite black and white, so let me say what I'm going to say. I worked in sports medicine, insurance medicine, and public health care. The most comfortable place is sports medicine because the athletes don't ask questions. They do what they're told and they're only interested in the outcome. So they come in, they've got a problem, we fix them, they go and play again, they kick some goals, everybody's happy. Do you think that patients, people in the public, are really, really interested in understanding the fundamentals of the 12 systems of the body? They don't. They're accountants and they're engineers and they're all kinds of other things and they're good at it. They don't need to be good at medicine. In fact, they don't even need to know they're being monitored. This is going to sound creepy in Germany, but if you could get a push notification which says, we noticed that you were walking a little bit strangely, how's the right knee pain? And you said, how did they know that? We've organised an appointment to go and see a physiotherapist to do an initial assessment. That's going to cost somebody 30 euros. And then you fix it immediately without any concern about injury in the future. That 30 euro investment, that convenience for that person, patients don't need to know too much more than that. They just need to know when to show up and trust the expert's going to help them out. Now, when you talk about patient education and getting compliance and getting to actually follow advice, all right, that's another discussion. Then we need to educate them. We need to give them reminders. I mean, I have a to-do list for normal everyday things, and I have to squeeze in the gym somehow. And I struggle with it, and I know how important it is to do some training. So there is a need to trigger people. Everyone needs to be triggered to regular exercise, a bit of meditation, sleep properly, eat properly, drink water, not too much coffee. Everybody knows this in an educated society. They're just not necessarily behaving the best way that they should. So there is opportunity to educate why you should do it, and there's opportunity to trigger people with some sort of sensor technology or some sort of informatics system. And I think we're on the way there. We're just stuck in devices, and we have to let go of devices and start thinking in terms of data. Our Connect sensor, which we use now, is a separate device. It costs 100 euros instead of a 200 euro camera system. It will be in all TVs, all telephones, all iPads, probably within the next 10 years. You will not need to know where the sensors are, but the sensors will know where you are. And if we can trust the people behind it, we will be able to get push notifications which say, you need a little bit of help this week. And I think that would be an extremely enlightened society.
Yeah, and for everybody, health is one of the most important things in life, yeah. And but we spend not so much money on it, yeah. We buy an Apple iPhone for over 1,000 euros, but for prevention we say, oh, 30 euros, no, maybe next year. And this is a shame at some point. And we have to show them, like with your software, what it's about, and if you have this in 20 years, you may not walk or something like this.
Yeah, I think that's the point. It's about how to seamlessly integrating those informations into the patient's system, if you may call it that way. Because, of course, you might just tell everybody what they already know. Watch your nutrition, work out more, don't get too much stress and all of that, and all of a sudden all the lifestyle diseases are fixed. So yeah, might be an easy thing to do, but it's about how to nudge them to do that. And I think this is the most important part, and so far nobody has really found a way to do that. So sensors might be a way to give them a push and incentivize healthy behavior as well. So we as a healthcare payer are doing that by giving them bonuses if they move more and if they go to stress courses and make their aqua gymnastics and all of that. But it takes more than that, obviously. So that's not enough. And is it not enough because it's not easy enough to people to deploy it on the individual basis? Or is it because they really don't care about it and think once a problem occurs, the system is going to fix it anyway. So I go to the doctors and everything's going to be fine again. And maybe you need to tell the people more that it's not going to be fine again, at least not at the same level. So fixing it is never as good as never having it occurring.
I think healthcare systems are from their nature quite conservative. So disruptions are difficult. Transformations are needed and are happening, but it needs time, and it also needs to take so many stakeholders into account, especially from the payer's perspective. You have the professional association who have quite a strong lead and very strong voice at national level. So on the other side, you need a balance to have also strong leadership at policy level to get an agreement when you are talking about transformations with electronic health records or digitization in the doctor's place. So with all the models, we have the one payer models we have in UK and in Scandinavia or also in Eastern Europe, where then you have the problem with waiting times or also with too strong governmental voice, and you don't have this government, the self-government as we have in Germany, with representatives from the payer side, from the insured side, and from the patient's side. Then you have on the other side the multiple systems, payer systems, besides Germany and France and Belgium, or also in the Netherlands. And according to the OECD, or also the World Bank, it said that, okay, the administration costs are quite higher, but on return, the quality is better and the access to health is also much better. But at the end, my point of view, it's important to stay with the solidarity. So with the principle, nobody should left behind. And they have this principle that the richest support the poorest, and the healthy, the sick ones. And with this principle, nobody left behind, with the improving the digital skills. So it's not only about looking at we have the newest and the best technology, but it's also to make sure that people can use this. And it's about digital skills, digital health literacy, and digital education.
I'm going to ask something that might be controversial. If we talk about solidarity and we talk about groups, often, and there's research actually that shows that if you're insured and a group pays for it, your behavior actually gets worse, right? Like, I have a minimal cost because other people will pay 90%. What about other models where your individual behavior is then rewarded and directly attached to your premiums or the payments you have to make? Like, what are your thoughts on that? I see you're ready to go to answer that one.
Yeah, I think the first point to make here is that what Kai already said, nobody really wants to be sick. So I think that's a thing we can all agree on. Maybe people don't know how to keep themselves healthy that good and as good as others, but I think that's the baseline. Nobody really wants to get sick. So, of course, from an economic perspective, that holds completely true. And I think it's not a good incentive to tell the people that they're covered. But on the other hand, if you think about Maslow and his pyramid, for instance, and you think about what people strive for and what needs to be achieved in order for them to develop the personality, then so the physical needs are on the very bottom line of it. So I think it's good that we have that covered, and also it's very hard to draw the line between diseases that people really can influence and things that just occur anyway. So if you think about genetic diseases, or if you think about autoimmune diseases and all of that. So at what point in time do you punish people for doing something, and what has been left out? Same applies to maybe risky behavior in terms of sports. If somebody drives a snowboard, that's obviously quite risky. At the same time, he's exercising and doing something for his body, and this is always where this discussion comes down to. Also, I'd like to stress that the solidarity-based systems, I think, are the best ones there are. So ours here in Germany has lasted now for 130 years, and I think that comes for a reason. If you think about how expensive treatment costs can be here, think about Novartis just put out a new pharmaceutical for people with muscular atrophy, and it's about 3.5 million euros. So who can pay for that? So it needs to be a very broad basis to cover the cost of that, and there's much more. So muscular atrophy is not that widespread, but if you think about rheumatic diseases, and if you think about biologic drugs, which can easily cost 20,000 euros a year, so that needs to be covered, and the solidarity-based systems, I think, are the best answer to that. The American folks, I think, have quite a different view on that, and I can agree from the economic perspective. I can completely agree with that as well. So it benefits the people that don't want to care about their health, and it benefits their families as well. So who's getting the most out of it? And it's the sick one and his beloved ones around it. If you're just taking it from that perspective, but that's not the way that I see it.
So we work with an insurance-sponsored wellness incentivization plan, which means you wear an Apple Watch. It happens to be an Apple Watch because you get it for free if you decide to follow this program. And everybody wants an Apple Watch. So they're immediately incentivized before they take their first step. You get this watch, you get to keep it if you're a good boy and you do your walks every single day. So there's the first incentive. The next one is if you go and buy vegetables with this green sticker on it from these supermarkets, then you get points. If you go to a gym chain and you have a personal trainer session, you get these points. And you accumulate your points and you get a free weekend with your wife and your kids at a spa resort, which happens to be a healthy spa resort. You get discounts on all your training equipment when you buy a new pair of Nikes. And people love this. Now, I happened to be at a strategy meeting with this organization late last year, and the long term, they've been running it for quite a few years now, the long-term benefits are enormous. Now, if you're worried about the people who are disadvantaged because they were born that way, but you take the added savings from the healthy populations and invest it back into the unhealthy, you can still have solidarity. You can still have a purse of money, more than you ever expected. I'm guessing this, I don't know it yet, because it's never happened. But you would have money. Now, this insurance company, they invest millions of dollars in underprivileged communities, particularly where they have their business set up. So they are giving back because they are saving. And they have such a high profile as an insurer for being the positive insurer. They own 85% of the market. Now, insurers see the commercial value in doing this. That makes sense. The government sees that the private actor is subsidising healthcare, but not only that, preventing people getting injured in the first place. Free HIV screening, no cost. Anyone can walk off the street and go to any pharmacy, give some blood, and be told if they have HIV or not. That's amazing. All paid by private, because the private actors see the long-term financial gain without any political pressure on them, which I think is quite nice.
So as I already told you, we are doing such things, and we have bonus programs. But interestingly enough, what happens with that is as soon as you pay people for acting healthy and give such incentives, and this is also tied to what we are allowed to do as a statutory body and what we're not allowed to do, there's a lot of discussion about this, if this is money spent right. So all of a sudden you get somebody who's sick and tells you, yeah, you're not paying for my, I don't know, let's just take a wheelchair, for example. So the excellence version of it with all the equipment there is, but you're paying for that shit. Sorry for the word I'm using here, but that's the discussion that already that just appears out of nothing if you're trying to do good with it, and it's also a field of tension we find ourselves in if we're doing that. But I think the bigger problem is what is the field, or what are the possibilities we have given by the law, and I think there's room for improvement there, and room to allow us to do more, because I think we would love to do more, but our range of action is quite limited on that as well.
So we have a few minutes left. As you can see, a quite lively discussion. We could go on for forever, but if we have any few questions from the audience, we'd like to hear from you as well. If you have any questions for anyone specifically, or a general question, we'd be quite happy to spend the last few minutes on you guys.
Hi everyone, I'm Noya Chen. I'm doing my PhD on IoT and healthcare, and obviously insurance company is an important stakeholder in my analysis. I mean, there has been a lot of concerns from the consumer side saying that we don't want to share our data, particularly with insurance providers, because we worry they may find out too much information, they have too much information, and they would increase the fee like huge if they find out, say, we have like factors which can lead to cancer or some other chronic disease at a later stage. So how do you deal with this issue as insurance company or insurance company representatives? Thank you.
Okay, so I guess I'm the one to answer that. Honestly, in Germany, it's not a big problem, at least not for the statutory health care system, because we're just not allowed to have that data. So everything that comes from a fitness tracker, for example, we are not allowed to have. And all other clinical values out of the lab, we're not allowed to have. And also, we have no incentive to base our insurance on the individual risk of the person in front of us. That's something that is quite tied to the private insurance business, where they do exactly that. And I know there's a lot of interest in that, so let me give you an example. I think half a year ago, I saw a company that are giving a prognosis based on your speech and on that behavior. So there are patterns, and they can tell you if you have had or will have some depression issues. And there was a stakeholder of the private insurance companies, and the first thing he thought of was, wow, that's quite interesting. So if somebody calls and says, I want to be insured with your company, and from only that sentence I can tell you what risk you are, I can just tell you immediately if I want to insure you or not. And so I think that's another good point for the solidarity-based systems here in Germany, because everyone that comes to us as a statutory health insurance will be insured, no matter what he has. He has cancer, he has hemophilia, he has lysosomal storage diseases, so all the very expensive stuff you're going to get covered. And that's a very big advantage of the system we have here in Germany, I think. But it's also, sorry for not being able to answer the question as you maybe wished to have it answered. But here in Germany, it's not much of a problem. So we would need to have somebody from the private insurance space to give a little more insights on that, I think.
Any other questions? No? Do you guys have any questions for each other? Any last closing ones? Go for it.
Back to regulations. So we talked about data protection and GDPR and all that. That's one side. Back to innovation and creativity. I think in Europe needs to pick up the speed a little bit in terms of regulation for digital health services. Everything's embedded in devices in Europe, because Germany has been famous for creating medical devices. Sweden's been famous for creating medical devices. If it's a pacemaker and you have to cut yourself open and put a piece of plastic and electronics in, there are rules that are designed to govern that, which is really, really good. I don't feel like the EU understands the nature of digital. America is much better. Now, digital's agile. It changes as you accumulate more data. So you can't have a waterfall approach to designing something which says we start the project now and in 3 years we have a finished product and you can sell that finished product for 50 years. Good luck with that. No, it changes on a week by week, if not second by second basis, and you learn along the way. That's the nature of digital innovation. That's why it's improving at exponential rates, as opposed to most of the other hardware devices. So the sensor area over there, I've been using that hardware in 1980s, and now it's here now and the public's buying it because they have access through a telephone. When is Europe going to increase the speed of regulatory frameworks which are safe enough but soft enough to allow software development processes to keep up with the rest of the world?
Well, I can tell you that this digital single market, or creating a digital single market, as we have already the single market, so it's the highest point on the agenda. We're discussing now the EU long-term budget for the period of 2021 to 2027, and Digital Europe is now was created as a new program with a quite high budget, I think about 9 billion euros. But where we are immediately staying in front of the challenge is that we can do regulations for products regarding the market access. But then the next step is this: the industry saying, okay, we are producing all this product, but it's not reimbursed by statutory health insurance. But then we are changing the competencies. So reimbursement is member state law, and the member states are very, very into that to check if the EU is not going into their competencies. So this is the main discussion we have in the European Council between 28, still next year 27 member states. They're checking if the European Union is not going to take any regulation on this reimbursement thing. And so we have this problem. We are trying to do. The European Commission is trying to do guidance, for example, but this is all non-binding, and you know by yourself, non-binding rules, it's not efficient. But this is the balance we need to find at European level.
But Glenn, I'm totally with you. In Germany, we have not a thinking problem, we have a doing problem, and I hope in the near future we move a little bit faster. And I heard 2021 and say, oh my God. And in 2020 they say, maybe 2025. And I hope it's get better.
Okay, just one last point, if I may.
Go for it.
So I think it takes broader regulation on the German side. If it's not obviously not done by the EU, because the member states don't want that. So what we can do is making selective contracts on any digital solution. The problem of that is the scalability, so we need a broader regulation for digital health products in the German healthcare space to fix that problem for the entire German population as well.
So sadly, we've run out of time, so I'm afraid I have to cut the lively and interesting discussion short. Thank you very much to the panelists for the great discussion, and thank you also to Science Services for arranging this and organizing this. I hope you had an enjoyable time listening to us, and have a great last day at the Medica. Thank you.